I'm gonna also.
Hey guys, welcome. We're gonna have some people trickling in the next few minutes. Just give us a couple minutes to get started here.
And just a couple ground rules. We love it when we see your cameras on, so we're not lecturing into the void. And if you wanted to put your institution where you're coming in from, that's always great too, so we can see where everyone's coming in from. All right, welcome everyone. I'll go ahead and get started. Thank you for coming today. This is another GOMI Wilderness and Emergency Medicine lecture series. If you haven't already, you're new to us and you like what we do, please feel free to follow us on Twitter and Instagram. It's @go_WME. We post there every week about what's coming up and reminders that it's happening. Our mission, if you haven't heard this before, is to create an educational platform where interested students and healthcare professionals can explore and interact with wilderness and emergency medicine, to showcase the diverse spheres in which physicians and healthcare professionals can make and impact and inspire others to think abstractly about the ways in which we can utilize our careers in healthcare and medicine, and to create an international community of wilderness medicine enthusiasts and experts committed to promoting a diverse and culturally competent environment. Hopefully, by this point, you know that you're getting in for a cold weather medicine lecture today. So take out your winter coats, get your snow boots on, and pretend that spring hasn't come. Also coming up next week, I'm very excited for Dr. Kjell Lindgren is giving a talk on space medicine. It's really exciting, and I hope you all will reserve your spots for it. Today, Dr. Andrea Alvarado is giving us a talk. She is a postgrad year 2 at the Jackson Holy Cross Emergency Medicine Residency Program. Prior to this, she completed her medical education at New York Medical College in New York, followed by a research fellowship at MGH in Boston. While originally from Venezuela, Dr. Alvarado spent most of her childhood growing up in South Florida, but while living in the Northeast, fell in love with snow and winter sports. Although her passion for diverse pathology brought her back to South Florida, she still remains passionate about cold weather activities. Her current interests within emergency medicine include critical care, medical education, and wilderness medicine. With that, I'll go ahead and get out of the way. Dr. Alvarado, you have the stage.
All right, let me share my screen so we can get started. Can you guys see my presentation okay? Perfect, I see some thumbs up. All right, so like we said, I'm Andrea. I'm one of the residents here at Jackson. I am super excited to talk about cold weather injuries, mostly because I love the cold, I love the snow, and as you can see, that is me on that picture buried in the snow. That is in Vermont during one of my snowboarding trips. I do not make enough money and I am not important enough to have any disclosure, so no conflicts of interest here. Our goals for today we're going to go through the pathophysiology and different stages of hypothermia. We're going to go through the stages and we're going to try to understand the management of freezing injury, most importantly, frostbite. And we're going to go through a few other cold weather injuries, which we may actually see in Florida, even though it's pretty warm out here today. Let's start off with hypothermia. So hypothermia can be either accidental or therapeutic. Therapeutic hypothermia is something that we do like in the emergency and critical care setting with the goal of targeting a specific temperature in patients that have just gone cardiac arrest in order to prevent further tissue damage in the setting of ischemic events. Accidental hypothermia is what we're going to discuss today, which is when your temperature drops to less than 35 degrees Celsius or 95.5 Fahrenheit, and it can be either primary or secondary. Primary hypothermia is anything that's caused by a cold environment. It's a person being out in the cold and becoming hypothermic, while secondary hypothermia can be caused by multiple factors. Secondary hypothermia can be caused by heat loss, like patients that present with a significant amount of burns, patients that present to your trauma department, they have this like massive blood transfusions, those blood products are cold and they can become hypothermic secondary to it. Recent birth, so that's why we put kids in a warmer when they are born, because children have a large surface area compared to their body mass. Therefore, they tend to lose a lot of heat. So that's another way in which that we lose heat and kids can become hypothermic. Secondary hypothermia can also happen with impaired thermogenesis. Our body tries to make heat by causing muscular thermogenesis, meaning that by us being physically active and making a little bit of heat, or by the shivering response, which is involuntary. Any medications or circumstances in which this is impaired can lead to hypothermia as well. And multifactorial, just like it sounds, toxicology, metabolic problems like adrenal insufficiency, mixed edema, coma, neurologic conditions, sepsis, shock, trauma, all of those things combined together can cause significant hypothermia in patients. In order to understand how we want to treat hypothermic patients, we need to truly understand the different ways in that we lose heat. Starting off with conduction. Conduction is when a patient comes in direct contact with a cold object. If we're talking about being in the hospital, this is when you have patients like on a cold metal boards when they come in from EMS and they're sitting on that cold board and they're transferring their body heat to those cold metal boards, or when they're sitting on that cold stretcher, sitting in our emergency department for hours and hours on end. Another way in which this can happen on outside is like if you're up in a mountain, you're sitting in the snow, your body's transferring heat to that snow that's around you. That's conduction. Convection is when your body comes in contact with either air or water. So if you're out on a windy, cold day, your body is going to rapidly lose heat based on the wind speed because your body is going to lose heat to that cold wind. Same thing if you have a kid that jumps in a cold lake, their body is going to lose heat to that cold water that's around them. And actually windy days and like flowing cold water are ways in which our body loses heat the most rapidly. We also lose heat via evaporation. So when people sweat, obviously you have liquid sweat on your skin. If there's a large temperature differential between your body and the environment, that sweat is going to evaporate and you're going to lose heat towards the environment. This can be avoided by covering patients with plastic wraps, putting sheets over them, and preventing this evaporation. We lose heat every time we take breaths, so respiration causes heat loss. And lastly, radiation. Our body creates electromagnetic waves that cause transfer of heat to our environment if the temperature around us is significantly lower. By that same token, this is how we get heat from like a bonfire because of those electromagnetic waves that transfer heat to us. So now that we understand the different ways in which our body loses heat, we need to understand how to conserve it and how our body and our system reacts to cold physiology. The first thing that would happen once your body is exposed to heat is that you're going to have a behavioral change. If you have a person that's awake and alert and they can move, they can react, they're conscious, the first thing they're going to do is try to look for warm clothing. They're going to try to find shelter. They're going to try to warm themselves up. If you have patients that are altered, they have psychiatric illnesses, or they're homeless people who don't have access to shelters or a warm environment, then they can become continuously more hypothermic. And that's when we get all the other physiologic effects of hypothermia. Starting with vasoconstriction. So vasoconstriction is a way in which our body tries to conserve heat. The idea is that you have vasoconstriction peripherally, you're shunting all that blood to your core, and you're preventing heat loss from your peripheries. The next way in which we try to conserve heat is by muscular thermogenesis. Like I said before, this could be voluntary or involuntary. Voluntary is awake and alert patients. They can get up, try some physical activity, try to warm themselves up. Or by shivering response, which is actually involuntary. Unfortunately, shivering can actually be impaired by multiple things like sedatives, analgesics, paralytics, like in the emergency department, once a patient comes in and we have to intubate them, we give them a paralytic, you're completely impairing that shivering response in that patient. Application of warm devices directly to the skin can also cause a diminishment of this shivering response and energy depletion as well. Also keep in mind that when patients start dropping their temperature to less than 31 degrees, their shivering response also gets impaired. The most concerning effect of hypothermia is actually its cardiovascular effects, and this is what leads to cardiac arrest. Initially, early on in hypothermia, you're going to get this elevated heart rate. You're going to get an elevated blood pressure secondary to that peripheral vasoconstriction. But if your body is not able to keep up with that dropping temperature, eventually this is going to progress to bradycardia, hypotension, and myocardial irritability. So once we get down to a temperature of 28 to 32 degrees Celsius is when you start to see this cardiac arrhythmias. This can be multiple arrhythmias. It can be anything from like AFib, A-flutter, or you can initially have a prolonged PR intervals, you can have a prolonged QTC, and even widening of your QRS. People tend to describe this Osborne J waves in hypothermic patients, which is that J-looking wave at the end of your QRS complex. But don't let this fool you, because this is not pathognomonic for hypothermia. You can actually also see this in intracranial processes like elevated intracranial pressure, or you can also see it in septic patients. And once we get to significant levels of hypothermia, we see significant metabolic changes. So once you have that peripheral vasoconstriction, your kidneys are going to feel like there's this hypervolemia in your body, and they're going to respond by what we call cold diuresis. So this is how patients become dehydrated. Hypothermia also causes muscle rigidity. So you might think that patients are actually in rigor mortis and that they're dead, but they're actually not. This is called pseudo rigor mortis. Patients can also have rhabdomyolysis, leading to kidney injury. And once we get down to temperatures of 34 degrees Celsius or less, you actually start having coagulopathies as well. Hypothermia causes impaired platelet function, it causes poor activity of our clotting factors, and it can actually lead to hemoconcentration and increased viscosity of the blood. So you get this DIC kind of picture, this like disseminated intravascular coagulation kind of picture. Hypothermia also causes a left shift in our oxygen dissociation curve, meaning that you have decreased oxygen unloading in your tissues. So your tissues are not receiving as much oxygen as they should. The one positive thing about hypothermia, which is actually what we tend to exploit in the critical care setting in the emergency department, is the fact that as temperature drops, cellular oxygen consumption decreases. There's some studies that suggest that there's approximately a 50% drop in cerebral oxygen consumption once your core temperature drops to less than 28 degrees. This is what we call the neuroprotective effect of hypothermia, and this is what we tend to exploit when we have patients that come in cardiac arrest. We get circulation, we get a pulse back, and we actually do what's called the targeted temperature management. So we intentionally make them hypothermic to protect their brain, to protect their neural function. And we'll talk a little bit more about that once we get to hypothermic cardiac arrest. So how do we manage hypothermia? In order to manage hypothermia, we not only need to identify the cause, but we actually need to identify what stage of hypothermia our patient is in order to figure out how invasive our interventions need to be. There are multiple stages of hypothermia, starting with mild. Mild hypothermia is when the core temperature drops to between 32 to 35 degrees Celsius. At this point, patients are conscious, they're shivering, and the idea is that because they're conscious, they should be awake and alert. You can bring them to a warm environment. You want to remove any wet clothing that's causing this hypothermia. You want to give them some of like grandma's hot soup. You want to make sure they're eating like warm, sweet drinks if possible. And you want to encourage them to increase their physical activity, have them walk around, have them do a little squat. Make sure you're triggering that muscular thermogenesis so that they can come back to normal temperatures. If all that doesn't work and your patient's temperature drops to 28 to 32 degrees Celsius, then that brings us to stage 2 or moderate hypothermia. Once we get down to this type of hypothermia, patients become altered, and you want to do all of the other things. You want to bring them into a warm environment. You want to remove that wet clothing. But at the same time, you also want to start minimally invasive active rewarming. While I'm more of a taco girl, this is what we call the hypothermia burrito. So you see we're wrapping up the patient in multiple things. The idea is that you're having this waterproof, this windproof wrap around them in order to prevent that convective loss of heat. You're removing all their cold or like wet clothing. You're applying heating pads. You're applying forced air in order to promote heating the patient. In addition to that, you want to give him some insulating blankets and you want to give him some headgear in order for to start warming up their head as well. Keep in mind that once we get down to these temperatures, so any temperature less than 32 degrees, patients are already at increased risk of getting cardiac arrhythmias. So you want to get these patients on a cardiac monitor if you have access to it. You want to get a core temperature monitor going so you can see if you're rewarming them appropriately. And ideally, you want to try to not move these patients too much, because since you're already in that cardiac irritability kind of stage, any sudden movements or any drastic movements can actually precipitate this arrhythmias in these people. So you want to prevent them from coding pretty much. If all of those things don't work and we get to the severe or stage 3 hypothermia, patients at this stage usually have a temperature less than 28 degrees. They're unconscious, but they still have a pulse. So their heart is still pumping. Unfortunately, because they are unconscious, this is a little bit more difficult to treat, and you need to think of more invasive ways in order to rewarm them. So you want to do all the other things that we said before, but you also want to start thinking of your ABCs of emergency medicine: airway, breathing, and circulation. If they're unconscious, they're not able to protect their airway, you want to make sure that they get intubated. You want to have IV access on these people so you can provide warmed IV fluids. And remember, your temperature is down to 28 degrees, so these people are at crazy increased risk of going into cardiac arrest due to myocardial irritability and dysrhythmias and hypotension from the progressive hypothermia. So once we get to this stage, you really want to think about getting them to what's called an ECLS center, which is an extracorporeal life support center, or as we see here, ECMO. ECMO is this magic machine that disconnects your lungs and your heart from your body. Pretty much you're providing a pump, which is your heart, and an oxygenator, which is going to be your lungs. And the idea is that you're bypassing your lungs and your heart, and you can actually use the ECMO machine to rewarm patients. There's actually been shown benefit of using ECMO in hypothermic cardiac arrest. So you always want to keep this in the back of your mind if you are either out in the wilderness and you're trying to figure out, where am I going to get these patients next? Am I going to get them to a hospital? Is there an ECMO center close to me where I can get these patients? Or if you're seeing these patients at a community hospital or a hospital that doesn't have ECMO, then you need to keep this in the back of your mind. Maybe I need to get this patient ready for transfer to an ECMO center so that they can start this type of rewarming. And in case that the patient goes into cardiac arrest, we have this like cardiac and pulmonary bypass system that can be done. If things get worse, then that's when we get to stage 4, or hypothermic cardiac arrest. So once you get to cardiac arrest, you want to do all of the other things that we talked about, but the only thing that you want to avoid is that you don't want to reheat the head. You don't want to rewarm the head. If a patient's in cardiac arrest, we want to exploit that neuroprotective effect of hypothermia. So you want to try to rewarm the patient, but don't do the headgear, don't do the warming to the head. Cardiac arrest can actually happen at less than 32 degrees Celsius, but it's most commonly at less than 28. Again, as you know, and as we all have learned, as soon as you feel that the patient loses their pulse, you start CPR, you start resuscitative measures. This is when you start thinking, I need to get this patient to an ECMO center so that they can be rewarmed, so that they can go in this, like, they can go into this bypass system to bypass the heart and the lungs and hopefully have better outcomes on this patient. We're gonna go a little bit deeper about how, what our rewarming techniques are. But to start off, the main thing that you should be focused on, especially if you're not in a hospital setting, like if you're out in a mountain and you see a hypothermic patient, think about physical barriers. Remove that wet clothing, dry the patient, cover them in a sheet or cover them in plastic so that they don't lose any more heat and so that they're protected against the wind and the elements. When we have a patient in moderate to severe or even like hypothermic cardiac arrest, like I said before, you want to have your core temperature monitoring. If you're in the hospital, in an ideal world, your best temperature monitor will be an esophageal monitor. Unfortunately, you can only do this if you have an intubated patient. And the reason why the esophageal monitor is better is because it's the closest one to your heart, so you can get a true core temperature. If this is not available, then you need to do rectal or bladder temperature monitoring, but unfortunately, these lag behind a little bit. And as we'll talk about in a little bit, this can actually be falsely elevated, especially if you're doing invasive rewarming measures such as like warm water, warm saline bladder lavage. So you're gonna have like that elevated temperature in your monitor when it's not really the core temperature of the patient, but more secondary to the lavage. Our goal temperature when rewarming patients is 32 degrees Celsius. You don't wanna overshoot and get them into like 39, 40, because hypothermia is not good for the brain. You just wanna get them to 32, get them out of that danger zone of myocardial irritability, and that should be enough. When we talk about starting warm IV fluids, you can start this in moderate to severe hypothermic patients and certainly in hypothermic cardiac arrest. The idea is that you want to increase intravascular volume and you want to prevent further iatrogenic hypothermia. So usually if you come to emergency department, the saline bags are sitting in an omnicell, which is exposed to the temperature of the room, which is usually very, very cold. Feels like a tundra in there. So you can cause worsening iatrogenic hypothermia if you just give normal IV fluids to a patient. So you just want to provide them with room temperature fluids. You don't have to like boil your normal saline bag to help your patient out. If they're in cardiac arrest, you can do a thoracic lavage. So for these, you want to heat up your saline bags to 38 to 42 degrees Celsius. And the idea is that you're putting 2 chest tubes in. One of them is giving the warm fluids, the other one is draining them out. It's similar idea to a bladder lavage. Bladder lavage you can use in patients with moderate hypothermia. And you're putting in your 3-way Foley, you're giving them those warm fluids that are 38 to 42 degrees Celsius, and you're taking all that out and monitoring as your temperature goes up. Keeping in mind, and don't forget, your goal temperature is 32 degrees. You don't want to overshoot too much. And there is this very famous saying, nobody's dead until they're warm and dead. This comes from the idea that hypothermia can actually mimic death. So hypothermic patients can actually develop fixed dilated pupils at 29 degrees Celsius, and they can even have impaired corneal reflexes at around 23 degrees Celsius. Like I mentioned before, hypothermia can cause muscular rigidity, and this can be confused with rigor mortis. So this is called pseudo-rigor mortis. And hypothermic patients can go into cardiac arrest. These are all the things that we look at when we're declaring a patient dead. So the idea is that you want to warm the patients to those 32 degrees before you terminate CPR, before you terminate your resuscitative efforts. But nothing in medicine is perfect. And even though we have these protocols, everything is based on our clinical judgment. So there are some exceptions to that rule. So when you're evaluating whether or not you want to terminate CPR in a patient who is not normothermic yet, there are certain situations in which you would terminate CPR when they're still hypothermic. This includes if the patient is frozen solid, the likelihood that they survive is quite unlikely, so you can terminate CPR before normothermia. Same thing if they have some type of irreversible injury, like if patients are decapitated, or if you notice signs of decomposition or truncal transection. All of these things, are not injuries that a patient will recover from, so there is no need to reach normothermia before ending your resuscitative efforts. Another situation is a case in which patient has a history of a witness arrest while they were normothermic and later they underwent subsequent cooling. You can terminate efforts in that case because their primary arrest was while they were normothermic. It's not a real hypothermic cardiac arrest. And if you are in a clinical setting, ideally, and you're resuscitating these patients, you want to get a potassium level. There is evidence showing that patients that have a potassium greater than 12 are very, very unlikely, like almost zero likelihood that they will survive. So you can terminate efforts before you reach that temperature of 32 degrees. But there are some spatial considerations when it comes to everything in medicine, especially kids. Kids are the exception to almost every rule. So children actually have this increased ability to tolerate and recover from hypoxic brain injury. They actually do really well neurologically, even with prolonged CPR. So in kids that had a cardiac arrest with rapid cooling afterwards, you can actually continue to do prolonged CPR, which it wouldn't be the case with an adult, as I said before. Drowning victims, also you need to differentiate drowning victims in adults versus kids. So kids have a higher surface area compared to their core mass. Therefore, they actually become hypothermic a lot faster than adults. So kids that drown, they can actually undergo rapid cooling simultaneously to them being hypoxic from drowning. So in these patients, you want to do prolonged CPR because they might have good neurological outcomes if you're able to revive them. Like I said, this is not the case for adults who have an hypoxic cardiac arrest after drowning. And actually, there's a picture of ice, like an ice swimming person. I didn't realize it's like an actual sport in some countries. It sounds crazy. Other spatial considerations are avalanche burial. So like I mentioned before, when you have wind and water, especially flowing water, causes a much more rapid drop in core temperature than conductive heat loss. So avalanches actually cause much lower drop in core temperature. So if you have a patient that was buried in an avalanche and you're able to recover them within 35 minutes of that burial, and they are in cardiac arrest, the chances that they have a hypothermic cardiac arrest are actually quite unlikely. And it's most likely that they aspirated like the snow and had asphyxiation secondary to that, or that they have some type of traumatic injury. If you recover a patient from an avalanche burial after 35 minutes of the event and they are in cardiac arrest, and you don't see any other signs of injuries, you don't see traumatic brain or traumatic injuries, or you look in the airway and there's no snow there, no evidence of asphyxiation, they might actually be in hypothermic cardiac arrest. And these patients are those that you actually want to do prolonged CPR in. And most importantly, hard circumstances. It's really easy for us to have ton of staff, ton of techs, nurses, providers if we're in a hospital setting. This is not the case if you have a hypothermic cardiac arrest in the field, like in a mountain where you don't have transport, you have to get a helicopter down there. So these are the circumstances in which we really exploit that neuroprotective effect of hypothermia. When you have a patient that goes into hypothermic cardiac arrest, keep in mind that because of that neuroprotective effect of hypothermia, you can not only do prolonged CPR, but you can actually do intermittent CPR. So if you don't have enough rescuers there, you don't have enough providers, your number one goal is to get to a safe environment so no one else gets hurt. And once you're able to start CPR, if you're the only rescuer there, there's no way that you can do continuous CPR the entire time. So there's actually some evidence behind doing intermittent CPR. So if a patient's core temperature is less than 28 degrees, you can actually do 5 minutes of CPR and then take 5 minutes to rest. If their core temperature is less than 20, then you can do 5 minutes of CPR and take a 10-minute rest. And there's actually been cases of patients that have had prolonged CPR, or even patients that had some delay in getting CPR done who've had really good neurological outcomes. And that's because of that neuroprotective effect of hypothermia. There's actually a case from 2019 where there was like an Italian mountaineer who got stuck in a glacier for 7 hours. He was 50 years old, he coded, his core temperature was 26 degrees, and he ended up going into hypothermic cardiac arrest. He underwent CPR for approximately 6 hours. Once they finally rewarmed him, they stabilized him. He was hospitalized for approximately 7 weeks, and he literally walked out of the hospital. Like, he had complete neurological recovery. So just keep in mind that if you don't find signs of non-survivable injury, you don't find, you think that this patient had a real hypothermic cardiac arrest rather than being normothermic and arresting while they were normothermic, they might actually do really good. So continue CPR, really advocate for them to get transferred to an appropriate center preferably a center that can provide ECMO for them, because patients do better in that sense, and they can have better like access to rewarming techniques. Like I said, you can bypass the lungs, bypass the heart with ECMO, and patients can have better outcomes. But hypothermia is not the only thing that we see in cold environments. So we're going to talk a little bit about freezing injuries, most importantly, frostbite. So frostbite occurs most commonly in populations such as military that trains in this high altitude, harsh conditions. It can occur in elderly patients, as well as patients that have some type of altermentation, patients that are intoxicated or have some type of psychiatric illness and they're not able to seek shelter and get rewarmed. Also, homeless people, if they're not able to get access to a warm place, to shelter, they're at increased risk of having frostbite. Frostbite usually affects most commonly the head and then followed by the hands and the feet. There are certain risk factors that put people at increased risk of frostbite. This is wind speed. Remember, we talked about that convective heat loss. So wind speed greater than 10 miles per hour, combined with a temperature less than -12 degrees Celsius, significantly increases the cooling rate. So that's why people are at increased risk of frostbite. High altitudes greater than 17,000 feet also put patients at significantly increased risk of frostbite. And this is me, but that's only 6,000 feet, I believe. So I think it was like only 30 degrees that day. So I definitely wasn't at risk of frostbite. I just really like the picture. And just a fun fact, if you touch a metal surface that is -15 degrees Celsius for approximately 2 to 3 minutes, you can actually develop frostbite in that skin. So a little bit about the pathophysiology of frostbite. This is very similar to burn injuries for people that have seen burns before. You have the zone of coagulation in the middle, the zone of stasis, and then the zone of hyperemia followed most superficially. The idea is that this middle zone, the zone of coagulation, is the one that is most distal, is the one that has the most damage, and there's almost no chance that you're going to be able to reverse that damage. You have irreversible cellular damage in this area. The zone of hyperemia is going to be your most superficial zone and is the one that has reversible damage, and usually patients tend to recover cellular function even without treatment in approximately 10 days. So the goal of rewarming and the goal of treating frostbite is to save this middle zone, the zone of stasis. This zone may have reversible damage, and this is where we get the most benefit out of treating and rewarming frostbite. But always keep in mind, and we'll touch base once we talk about frostbite management, that the most damage when it comes to frostbite occurs during thawing and rewarming. So thawing leads to significant endothelial damage because you get this arachidonic acid cascade, you get vasoconstriction, you get platelet aggregation, venous and arterial thrombosis. So patients can have some ischemia, necrosis, and gangrene once we're thawing. And we'll talk about refreezing injury and the risk of that thawing, refreezing kind of cycle that can really hurt patients. First degree frostbite affects the epidermis. It usually leads to this like erythema and edema in the area. Patients will come in with a stinging or burning sensation. They have minimal pain with rewarming, and the prognosis is fantastic, that they'll have almost full recovery of that tissue. Second degree frostbite is similar to a full thickness burn. So you have epidermis and dermis involvement. You have edema, you have these clear blisters that are actually filled with cytokines, they're filled with thromboxane, prostaglandins, and these blisters don't develop immediately, they actually develop in like 6 to 24 hours. Usually these patients will present initially with numbness, and then they'll have this like achy throbbing sensation. They have moderate pain with rewarming, so don't forget to treat their pain once you're rewarming their limbs or the affected area. And they tend to have good prognosis for recovery of those cells in that tissue. Third degree frostbites are when you get down to the hypodermis, you have this hemorrhagic bullae. These patients have severe pain when you're rewarming that affected area, and the prognosis is not so good. And last, this is our fourth degree frostbite. This is when patients get down to like the frostbite gets down to the skin, the muscle, the bone. They have this like gray, black areas, and this is completely insensitive to rewarming. This is extremely poor prognosis. A lot of these patients will have to undergo like amputation or significant debridement of the affected area. Keep in mind that while this might be insensitive because you have significant nerve damage, the patient will not just simply have 4th-degree frostbite, but in other areas, they might have 1st, 2nd, and 3rd degree. So make sure you provide them with appropriate pain relief once you're rewarming them. So this is where the distinction between pre-hospital and hospital management of frostbite comes in. If you see frostbite outside of the hospital, your number one goal as a rescuer, as a provider, or as somebody that wants to help that person is to prevent further injury. You want to assess the person as a whole, make sure you're preventing hypothermia, bringing them into a warm environment, provide physical barriers, try to prevent dehydration, give them fluids if you need to. But number one is that if you're not out of the harsh environment, you're not out of that risk of refreezing, do not start heating up those areas. Do not start rewarming that area of frostbite, because again, thawing is the part that causes the most endothelial damage and can lead to the most tissue damage. So you want to wait until you're in a hospital setting or completely out of that area or the risk of getting that refreezing injury before you start thawing the patient. Once you get to the emergency department, then you're out of that danger zone and you can actually start rewarming the patient. Ideally, you want to dunk the limbs, if it's a limb, into a warm water bath. The temperature of the water should be between 37 to 39 degrees, and you want to keep those tissues there for approximately 20 to 30 minutes or until the skin is like pliable and erythematous. If it's an area of the body like the face or the ears that you can't really dunk into water, you're not going to like put the whole entire patient in a warm water bath. So in that case, you want to use moist compresses and just apply them to the area that's affected. Provide appropriate pain control. You can try some aloe vera or ibuprofen in order to fight that arachidonic acid cascade and that inflammatory cascade. Antibiotics are a little bit controversial in this setting. Most people don't use them unless you feel like there is some risk of infection. And usually the most common bacteria that affect the skin would be staph and strep. So if you feel like you need to give antibiotics, make sure you cover for those. And early surgical consultation actually leads to poor prognosis. The idea in these patients is that you want to rewarm them. You want to give them some time to reperfuse that tissue and see how much tissue they can recover on their own before you get a surgical consultation. Because if you get the consultation significantly early on, you didn't give the patient enough time to see if they had recovery of that tissue. And they might actually undergo amputation or debridement of more tissue than they would have if you would have given them a little more time. So just give them a little time before you get your surgery friends involved. And now we're gonna go through a few cold injuries. These you can actually see in Florida, and these I have actually seen in Florida. So let's start with a case. This is a 61-year-old homeless gentleman. He came in complaining of bilateral foot pain after walking around on a cool, rainy night. This was actually a real patient that came into our Fort Lauderdale hospital. I think it was like in December after like a rainy night. So, you know, Florida, December, which is like 40 degrees at night on like a super cool night. So this patient actually presented with trench foot or immersion foot. This is caused by prolonged cooling and wet conditions in the shoes. It causes significant damage to soft tissue as well as peripheral nerves. So patients will come in with like this numbness, tingling, and when you're examining, they'll have this like pale, mottled appearance to their feet. If they present really late, they might actually be pulseless and they might not be able to move that foot. Unfortunately, treatment is very limited. The only thing you can do for these patients is rewarm them, give them appropriate pain control because they're going to have severe, severe burning pain once you start rewarming them. And keep in mind that approximately 2 to 3 days after you rewarm that limb, they're going to have edema and some bullate formation. And advise them that peripheral nerve damage is actually permanent, so they might have permanent anesthesia of the feet after this type of injury. Later on in the day, you get another patient that shows up to your ED, and this is a 12-year-old male that presents with his parents with pain at the tip of his nose. In the same area, he has a blanching nodule, and his parents report that they arrived from Texas to go skiing for the first time, and their child's symptoms developed a few days after arriving to their skiing trip. You see this, and this is actually called Pernio or chill veins. So these are uncomfortable inflammatory lesions. They are actually caused by intermittent exposure to like cooled and damp environments. They occur most commonly in the feet and the hands, but they can also happen in the face, the ears, and the lower legs. Patients usually come in with this like early like tingling and numbness sensation, and over the next 12 to 24 hours, they can develop edema, erythema, some cyanosis in the area. They will complain of like this like very itchy and like burning paresthesias in the area. Your goal is to rewarm the area. You can do warm compresses, and usually they recover pretty well in the next 2 weeks. If this is a patient that has recurrence of Pernio or chill veins, and they're continually exposed to that cold, damp environment, you can try like prophylactic vasodilation with things like nifedipine as well. And that same day, you get another kiddo, but this time in Florida. This is a 3-year-old female that presents with a red lesion in her cheek. Her parents report that they first noted the lesion after the babysitter took the patient to get a popsicle in a hot day. When you come in to see the patient, you see this, and this is actually panniculitis. In the case of that clinical presentation with a popsicle, we actually call it popsicle panniculitis. This is necrosis to the subcutaneous fat. It's caused by prolonged exposure to cold temperature. So in the case of children, like if they're putting a cold popsicle like inside their cheek for a while, this is what can happen. There's no treatment for this really. Once you get necrosis, that's kind of irreversible, but younger children tend to do really well, and scarring tends to be very minimal. It just takes a few weeks for them to recover once you remove the inciting trigger. And lastly, you have a 25-year-old female that presents with an erythematous, raised, itchy lesions on her back. She denies any new skincare products, and she reports that she was feeling fine until a few minutes after she went swimming in this cold underground cave. For anyone that's from Florida, she probably went to Devil's Den. And you see this when she comes in. This is called cold urticaria. This is similar to an allergic reaction. It's a hypersensitivity reaction to cold air or cold water. Usually patients report that it develops anywhere between like 2 to 5 minutes after exposure to the trigger. And usually it resolves spontaneously in approximately 2 hours. But if you have someone that comes in like this and they're pretty uncomfortable, you can try antihistamines like your Benadryl, similar to how you would try in an allergic reaction. There are very rare case reports of patients actually coming in with like cold-induced anaphylaxis, actually requiring like full epinephrine and significant treatment for these anaphylactic responses. This is extremely, extremely rare, but just to keep in the back of your mind if you have that kind of presentation. And these are all the topics I wanted to discuss. I just want to go through a few take-home points that I find the most important when it comes to managing these patients, either outside of the hospital or when they first come into your emergency department. So number one, with hypothermia, don't forget about physical barriers. That's the most important part. You want to prevent further heat loss. So cover up these patients, put on a plastic wrap, take away all the cold clothing. If it's a hypothermic patient that's sitting in your cold stretcher in the ED, try to cover that stretcher with some warm sheets and prevent further heat loss as well. Don't forget about doing prolonged CPR in hypothermic patients. Because of that neuroprotective effect of hypothermia, these patients can actually do really well. So don't give up on them, advocate for them, and make sure that you try to get them to an ECLS center or an ECMO center where they can get appropriate treatment, as well as they might benefit from those centers. Keep in mind refreezing injury. If you're out skiing and you see somebody that might have some type of frostbite, don't try to rewarm them. Don't try to heat up that or reheat that area if you're still out in the cold, because you're going to get that inflammatory cascade that is going to cause significantly more tissue damage if you go through that vicious cycle of thawing, refreezing, thawing, and refreezing. Just make sure you get them out of that harsh environment. And once they're safe and there's no risk that they're going to have that refreezing injury, then you can start warming them up. And don't forget the cold injuries can actually be seen in Florida. So think about your popsicle panniculitis once you're doing your pediatric ED rotation. Think about trench foot, which we've actually seen in Florida. And actually hypothermia can actually happen in Florida as well. Don't forget, especially at Jackson, we have a big homeless population. Sometimes these people don't have shelters, and our temperature down here does drop sometimes to 30. So if they're out in a cold night, you might get to see these hypothermic patients in our emergency department, even if you usually don't live like up north or in a very cold setting. Just keep it in the back of your mind so that now you know how to assess what state you're in and how to treat it. These are my references, and these are my pups. This was a trip that we did in the Appalachian Trail a few months ago, and they absolutely love the snow. 2 huskies. And that's all I got for you guys. If you have any questions, feel free to ask.
Thank you so much, Dr. Alvarado. That was an awesome talk. Yeah, so everybody, if you have questions, you can put them in the chat and I can read them out, or you can go to reactions and raise hand and you can ask them aloud. I have a question off the bat. We recently had a snowmageddon here in Tennessee, which was like the first time in 10 years or something. And I was really worried about my girlfriend getting frostbite. Her foot was, super red. We had been out there for a while. But my question is about if people have Raynaud's phenomenon, is that an increased risk of frostbite? And then kind of on the converse side, is there any role for vasodilators in the field, something like nitric oxide or sildenafil or like a calcium channel blocker to open up the blood flow and kind of reverse that vasoconstriction?
So I haven't read much about vasodilators in frostbite. I think the #1 standard treatment is rewarming. So cold temperatures definitely put you at increased risk, especially if people that have Raynaud's phenomenon. So rewarming is the mainstay of treatment for those patients. That said, like I said before, I've actually done this lecture before for our other residents. And before I thought you could just start rewarming patients in the field, but turns out that's actually more dangerous for them and it causes more tissue damage. So unless you're out of that dangerous environment, I would say just wait until you get to a safe area, wait till you get back home and then try to rewarm that area.
Gotcha, that makes sense. Kind of in a similar vein, we have a question from Dana on, Linda first, on is there a role for TPA in frostbite if you confirm that there's a thrombosis on arteriogram? So
that's actually one of the things that I was reading about a few days ago. And it seems that there really isn't much evidence to show that like TPA or even anticoagulation will help in this type of cases. In other type of cold injuries, they have recommended, not TPA so much, but some type of like antiplatelet medication. But I haven't seen it recommended in frostbite now.
Gotcha, thank you. We have a question from Dana that is, when should we be concerned about after drop and what is the best way to prevent and manage after drop?
So you should be concerned if you're out in the field and you're not having, so that's where the goal of core temperature monitoring comes in. So you want to make sure that you're able to rewarm these patients and get them out of that danger zone. Keep monitoring the temperature closely. These patients need to be in an ICU setting, and that's where invasive rewarming measures come in. So you just want to get them out of that dangerous environment, get them to a hospital where they can have close monitoring, and most importantly, get that core temperature, like that esophageal probe if you can, to avoid that after drop in temperature that can cause like recurrent hypothermia and again, that myocardial irritability and worse outcomes.
Awesome. Thank you. From Larry, we have a question. You touched on this a little bit, but on using ibuprofen during frostbite and rewarming to interrupt the cascade, inflammatory cascade. Could you just reiterate what you said on that?
Yeah, there is a few reports of like actually the benefits of using things like aloe vera and using ibuprofen, as they might prevent this inflammatory cascade and the arachidonic acid cascade. Unfortunately, I couldn't find clear evidence on like how long you actually use the ibuprofen for, but it seems that some people have used it in the past to help with these types of injuries.
Awesome. We're doing rapid fire here. Thank you for answering all these. So Scott wants to know kind of what you mentioned of in a hypothermic patient, you could potentially trigger arrhythmias when they have very low core temperature. Wondering what kind of, if there's any specific movements that are more prone to trigger those.
I think anything that would cause a patient to increase their heart rate and become tachycardic is going to worsen that, or any drastic movements. Unfortunately, when you're thinking about these hypothermia patients in the field, there isn't a lot that you can control. I mean, obviously, I don't go around and like shake the patient, but if you need to get them out of that dangerous area, you need to get them out of that avalanche, or you need to get them out of that glacier where they're stuck. There's nothing else that you can do. You have to save that patient and then deal with the consequences later.
Awesome. Sounds good. One question related to, so we had a talk a couple weeks ago from Dr. Van Tilburg out in like Seattle area and, by Mount Hood. And he talked about this case of these people who were performing CPR out in the field for like 2 hours, and how that was, that was a risk because they were in an avalanche zone. But you mentioned a couple times today about extending CPR lengths. And that guy in the glacier, going for 6 hours. From when I was in EMT, it was about 30 minutes is kind of when we started calling things in the field. Is there a timeline that you would kind of give a hard stop, or is it really just until they're rewarmed?
You mean like a hard stop to terminate CPR and just pronounce that?
Yes.
So it's a clinical judgment. So I haven't actually seen a hypothermia patient before, but in doing some research on this topic, it really is a clinical judgment. Ideally, if you don't have any other source of injury and you know that the patient doesn't have any other like non-survivable injuries, and you really think that this was a hypothermic cardiac arrest, they will benefit from prolonged CPR. Unfortunately, it all depends on what you have access to. Can you get that patient out of there? Can you safely get that patient out of that environment? Or are you risking the lives of the rescuers too? It's the idea that if you have this neuroprotective effect, you could do prolonged CPR. You could even delay CPR until you get to a safe area, but that all depends on what kind of resources you have. And it really is a clinical judgment. Unfortunately, it's not really black and white. There are protocols saying that you can stop if you have your potassium greater than 12, or if you the patient is like completely frozen solid, or if you have other evidence to suggest that they arrested while they were normothermic. But the rest is really clinical judgment and what kind of access you have to getting that patient transported, getting them out of there, and how safe it is to get them out there and continue to do CPR.
Definitely, that absolutely makes sense. We have one question of once the core temperature reaches 32 degrees Celsius, is there any risk for hypothermia happening again? So like kind of once you get over that mark.
Yeah, so if you get that after drop, then so that's why you need to make sure that you have good core temperature measurements, preferably with a esophageal probe if possible. And the idea is that you don't want to overshoot and make them hyperthermic, because then that has also worsening outcomes and when it comes to like neurological damage. So yeah, you run the risk of after drop. That's why you have to make sure that you have close monitoring of these patients.
Sounds good. And I think the last question that I have, unless something else pops up, is one that we got in our form before the talk of whether you have any recommendations for treatment for chronic chilblains.
Yeah, so in these patients, you can do prophylactic vasodilators. Nifedipine, I think amlodipine is another option if I'm not mistaken.
Cool. So that, yeah, maybe there is something to my hypothesis of using those for frostbite, but
Yeah, I'll look
take
into it and see. Yeah.
Sounds good. Well, I'm not seeing any other questions. So thank you so much for your time. Thank you for everyone for coming. That was an awesome talk, and I hope I can get out in the snow soon and put some of this to use again.
Thank you all so much for having me. I appreciate it.
See you guys. See you all next week for our astronaut and space medicine talk.